And as we're waiting for that, as Christian and Tom have said, we are focusing today in this second SSA forum on vulnerable older adults and long-term care and intersections with palliative care. So the overall program objectives today are to provide a meta perspective on the pandemic and the pandemic environment globally in the United States and at the state level, particularly New York and Connecticut, frame the key public health law and policy issues. And by the way, I am a healthcare attorney as well as a gerontological social work researcher. We'll be talking about human rights, not only the right to health, but the right to palliative care and the right to be free of abuse, mistreatment, and neglect. We'll give a snapshot of the long-term care continuum with particular emphasis on integrated palliative medical and social services. And we'll ask you to keep in mind as we move along the question, what could have been done better during the pandemic? And then finally, we'll have two excellent presenters at the conclusion. One, Dr. Katherine Pettus, giving us the advocacy perspective, and our colleague Carla Usher, giving us the community perspective. Next slide, please. Laura, next slide, please. So my focus today in my particular presentation will be what I call the entanglements of scarce resources during the pandemic and triage decisions, age and disability, implications for public policy, social and health justice. I'll also talk a little bit about the role of federal and state governments, global actors, including the WHO, the importance of institutions and systems, especially public health systems and educational institutions. And then we'll talk across the board about the need to expand palliative care as a response to this pandemic. And Tom, given what you've already heard about his workforce education and training grant at the Finger Lakes Center, we're going to talk about how to expand workforce education and training. Next slide. So you're all aware, I'm sure, that we've had declared public health emergencies, both internationally, here in the US, and of course, in many states, including New York. And this is not the first time, certainly in the United States or globally, that we've been dealing with a crisis of this kind. Of course, we had the Ebola crisis in this 21st century, influenzas, and the impacts of climate change that we're seeing in tsunamis, hurricanes, fires in the western states. And but the COVID-19 crisis has presented perhaps what we call a perfect storm. It's again a global public health crisis, and we want to really emphasize that today, and spread globally and in the United States. Earlier in the year in New York was the US epicenter, but that has changed a little bit. There are some of the numbers from the Johns Hopkins dashboard. These numbers are staggering. Next slide, please. So I would call these, in addition to public health crises, also crises of equity and justice. And I want to mention today emerging theory that I think will help us carve out paths for activism and advocacy in the future. Colleagues at the Network for Public Health Law from UCLA, who are cited below, have identified the relationship of structural racism to public health. And of course, this is not a surprise for us. We are very aware that there's a gap in health across racial groups, glaring health inequities and disparities that have been exposed by this pandemic, but certainly existed before the pandemic. We're seeing racialized violence. And these colleagues at UCLA are talking about an interesting reconfiguration of how to look at civil rights and public health. In many cases, they've been seen as really oppositional, but these colleagues are talking about how civil rights and public health can cooperate to build civil rights, advocacy, and social justice movements. So I think this is a very important new body of scholarship we're seeing. Next slide. So on the global stage, and our colleague, Dr. Katherine Pettus, will talk more about this a little later. Certainly, we're aware of the World Health Organization and its very key role in a crisis of this kind. In May, the 73rd World Health Assembly, which is the decision-making body of the WHO, adopted a resolution, COVID-19 response, really recognizing the important role of palliative care services in the pandemic. So this was very welcome because many of us who work in palliative care understand that palliative care has been marginalized. And I think during the pandemic, it's become apparent that palliative care does have a very important and central role to play in public health policy. Next slide. So in my role as a healthcare attorney, I was honored to be asked to serve as the chair of the New York State Bar Association Health Law Section on task force, COVID-19 task force. We've been working now for many months to adopt recommendations, and I share with you here 3 of the key recommendations on legal reforms that we have framed, and these will be released very shortly. One is adoption of a State Emergency Health Powers Act, drawing on the Model Act that was written by Professor Gostin at Georgetown and Professor Hodge in the Network for Public Health Law in 2001. New York, by the way, we have done a gap analysis of the laws here in New York, does not have such an act. And certainly that was detrimental to us during this crisis. We're also recommending adoption of crisis standards of care, also written by our colleague Larry Gostin and James Hodge under the aegis of the Institute of Medicine in 2012. Again, New York did not have crisis standards during the pandemic. And for those of you who may be wondering what those standards are, they're really crisis the standards that come into play when we have disruption to normal healthcare operations, such as we're seeing throughout this pandemic. And I'll speak a little bit more about them in a few minutes. The third recommendation is adoption of what we call resource allocation guidelines based upon the 2015 New York State Task Force on Life in the Law ventilator guidelines. Now, what does that mean, resource allocation guidelines? Well, many of my colleagues in New York City and beyond, and certainly Tom can comment on this, have given testimony that there was scarcity in New York City. And by that, I mean not enough ICU beds, not enough staff to run ventilators, and not enough PPE. So when we have scarcity in that sense, we have to have uniform guidelines that help the people on the ground, the physicians and the other healthcare practitioners make decisions. And once again, we did not have these guidelines during the pandemic. We did write to the governor and the Department of Health, but no action has been taken to date on adoption of such guidelines. And finally, we are recommending that all actors in this global public health crisis ensure equitable access to palliative care for all persons to mitigate suffering. And this is really based upon the ethical principle of non-abandonment and duty to care for all persons. Next slide. So a little bit more about these crisis standards and how they have really mapped out an important, I think, plan for expanding palliative care in disasters and emergencies. And I certainly would encourage you to take a look at them. They're calling for, again, access to specialized medical care as appropriate, but also social supports and services, management of pain, which of course is very, very important, access to essential medicines, and also not to be overlooked, and as we've mentioned already, workforce education and training, not only for the health professionals, but also for all healthcare workers. And the authors of the crisis standards have provided an ethical justification for palliative care as a cross-cutting issue. And they describe it as an ethical and medical imperative. And a little bit further down, you'll see every attempt to offer pain management and comfort care to disaster victims must be made. And that's probably particularly important in the case that other care may not be accessible. Next slide. So a little bit more about what palliative care looks like here in the United States. And I know I've had this discussion with Dr. Pettus about how the United States has done on palliative care compared to the rest of the globe. Certainly there are other countries that are more advanced than we are, but here in the United States, Diane Meyer at Mount Sinai and the CAPSI, the Center to Advance Palliative Care, has been a leader in developing palliative care and different models of care. And one of the deficits under which we've suffered here in the United States is that, unlike hospice, palliative care does not have a dedicated financing stream. I think Dr. Caprio will talk a little bit more about this in terms of the continuum of care. Next slide. So I'd like to spend a few minutes on the nursing home aspects of this long-term care crisis. And I'm sure all of you have seen much in the news about this. I'd like to, again, acknowledge that many deficiencies predated the pandemic. And there's an excellent article actually that just came out in the Health Affairs Journal about this. And some of those deficiencies included infection control, inadequate staffing, inadequate staff training. Nursing homes have been historically underfunded, and certainly a failure to integrate system-wide palliative care in the nursing home environments. The data, tells part of the story. 40% of the U.S. death total were nursing home residents and workers in nursing homes. And of course, we know now, but hopefully we'll get a clearer picture as we move forward, that this crisis has disproportionately affected Blacks and African Americans and people of color. I do want to here pause for a minute and not just talk about the systems picture, but the human faces. And we're very happy to have Carla Usher with us today, who's going to share a little bit about her experience as a family member. The stories of nursing home residents, and again, I'm not suggesting that Carla's family member was in a nursing home, but just that family perspective, that community perspective, the suffering that families have experienced, the heightened risks of abuse, neglect, and violence because of the social isolation and the conditions of confinement, and certainly risk of serious human rights violations, as well as the psychosocial needs as a result of the experience of profound losses, bereavement, and trauma. Next slide. So future directions in terms of palliative care, CAPSI has just come out with a wonderful report on community-based palliative care, and this is increasingly important. And I know that Dr. Caprio, Dr. Lang, and others may touch upon this, but we're really working very hard to push palliative care out of the four walls of the hospital into the community. And some of the things that our colleagues at CAPSI are emphasizing here are consistency across those transitions of care, palliative care that is broadly accessible, that is prognosis independent, in other words, really responding to the needs of the seriously ill person, and emphasizing collaboration and coordination. Next slide. So workforce education and training, I am the founder and chair of the Collaborative for Palliative Care, and many of the presenters today work with the Collaborative for Palliative Care. We're pleased to be partnering with Dr. Caprio at the Finger Lakes Geriatric Education Center in the development of what we call generalist level education and training programs. For the last more than 5 years, we have been developing and offering a postgraduate certificate program in aging and health and healthcare management, gerontology, and palliative care. And I do want to let everyone know who may be interested that we will be launching that virtually for the first time in January 2021. And we certainly urge you to consider it if you're interested in palliative care. And Tom will tell you more about the Finger Lakes Geriatric Education Center and their initiatives. Next slide. So on that note, I'll close my remarks and ask you again to keep in mind that question I posed at the very beginning. What could we have done better during this public health emergency and crisis, unprecedented in our history? Thank you so much.
Thank you very much, Mary Beth. That's a wonderful way to kind of frame our discussion. I'm going to share my screen now and talk a little bit about what I've termed as being stories from the front line, if you will, from the pandemic. I just want to verify, Laura, can you see my slides?
Yes, I can.
Okay. So perspectives from the front lines, and again, this is both a combination of the experiences that I've had as a clinician during COVID-19, but also the collective experiences that I think of many that are working on the healthcare side of things. I know there's many of my colleagues that have joined today. Again, I'm Tom Caprio. I'm a geriatrician, a physician. I'm also a hospice and palliative care physician, chief medical officer for the University of Rochester Home Care and Hospice program. And I'm a nursing home physician. And so I'm going to be talking about sort of this idea of the continuum of care and what was experienced, kind of framing again about what are some of the elements of context that Mary Beth had set up to begin with her presentation. I think, again, we don't want to overdo this in terms of discussion, but we have to think about COVID-19 and what it is, and the fact that this new virus, this new coronavirus of SARS-CoV-2 is the official sort of scientific name for it, started to spread across the country, widespread in March. And it really was unprecedented, as like Mary Beth had talked about, in the sense that we had never really experienced, certainly in our generations and certainly lifetime for most of us, anything even close to the scale of a pandemic. But the other thing to kind of keep in mind is that this was a very kind of unique infection that, you know, I can talk about just from the clinical side of things, is that we were learning new stuff every single day and trying to keep up with the information that was coming out from both state and federal authorities about what was happening and what they thought about in terms of infection prevention and transmissibility, and what were the actual sequelae in terms of the infection. That we began to understand is that this was not just sort of a simple respiratory infection. This was not like influenza. This was a systemic disease affecting multiple organ systems, having variable manifestations and a very wide spectrum in terms of the severity of disease, where some patients ended up in the hospital extremely ill, requiring ICU level care and ventilator support because of respiratory failure, and others had more mild to moderate sort of disease that could be managed safely in more community-based settings, and some being asymptomatic and spreading the infection in other ways as well. And so thinking about all of these sort of complexities and a lot of the changing guidance that came along about what types of masks you need to wear, that we need to wear masks all the time, or just when you're encountering patients. And you can imagine from sort of what I describe as the end user perspective, right? Someone who is working in home care, whether this be a home health aide or working in the nursing home, a certified nursing assistant, or a physician or a nurse that is doing the direct patient care, is that there at times appear to be conflicting information. There appeared to be changes in terms of, well, we don't have the supply of this type of PPE, and so we have to substitute this. And you can imagine that how this creates both confusion, distrust, and a lot of additional anxiety in addition just to the clinical care that was being provided. This is kind of where I sat beginning to mid-March and through the rest of really the first wave of the pandemic, is thinking about the discharge planning process. And we actually had, when we think about with home care and hospice, kind of I described as the luxury of a little bit of time to be able to manage some of our protocols and begin planning, because we saw the first wave of patients entering into the hospital being very critically ill in the ICU, closing down wards to make them COVID-only wards and those sorts of things. But then realizing that those that survived the acuity of this illness were then going to be transitioning out and require care in other settings, whether they go home, into the nursing home, assisted living facilities. And then each of these kind of facilities were also struggling with their own sort of infection control and mandates from the state and those sorts of things. So it became a very complex process of being able to understand what's the best way and best path to move forward with this. At the same time, we have to understand is that the hospitals were becoming overwhelmed and really requiring the fact that they needed to maintain the beds for the most critically ill patients. So this is where, when again, thinking about the continuum of care, is that for those patients that were not necessarily as sick with COVID-19, or those that were just our regular patients that we saw before the pandemic with heart failure and chronic lung disease and those sorts of things, they were petrified about ending up back in the hospital. And so what do we do in terms of addressing their goals of care and being able to support them from a clinical perspective so that they weren't going in the hospital? I had many patients that were saying they did not want to go into the emergency department for evaluation, when, you know, best judgment and effort and normal circumstances, we would have said, you know, with your heart disease, you need to go in to the hospital, be evaluated, but they were scared with it. And so this created an imperative to sort of think about how on both sides of the equation are we being able to provide the community support and resources. And then on the hospital side is the patient's care oftentimes would continue outside those hospital walls. And so this slide shows here, this is a snapshot of the COVID-19 data from CMS. The vast majority of these patients are what we would describe as dually eligible Medicare and Medicaid patients. You can see that almost a third of the patients died in the hospital, but a significant number, 27%, being discharged to home, over 20% to a skilled nursing facility, more than 10% to a nursing or to home health services. And so this created imperative to prepare our community resources to be able to accept these patients and reduce the risk that they would be in the hospital. And the thing I have to emphasize is those that were hospitalized, the most critically ill with COVID-19, these were very, very sick patients. They had a length of stay, for many of them exceeding a week period of time. And by the time they came out, significantly debilitated and requiring ongoing care. It wasn't just like suddenly they were over their illness and they could just go home. And so this really kind of underscored what I think about in terms of a lot of the continuum of care, particularly with home care, is that we were both focusing on the potential wave of patients that had the infection with COVID-19, but also the care as usual. Like I mentioned, those patients with chronic heart disease and chronic lung disease, prevent them from going into the hospital, and then providing that continuity of care as the COVID-19 patients were then being transitioned home. We also were leveraging technology, and I kind of, you know, it's almost embarrassing to say this, is that I have the technology to do telemedicine for visits existing for years now. I've never done a telemedicine visit until COVID-19. And now I'm about 50-50 in terms of hybrid of in-person and telemedicine, doing video visits with it. So we had the technology, and it was about trying to quickly pivot that to be able to do that, as well as remote monitoring. So for patients in the home, monitoring their oxygen levels and blood pressure and heart rate, so we could identify early parameters of changes that they could be getting sick again and hopefully prevent that rehospitalization. And for the experience with our home care agency, we actually had very few rehospitalizations of COVID-19 patients that went home, I think, and that's really a tribute to the tremendous work of the teams. And when we think about palliative and end-of-life care, particularly with hospice care, then we began seeing the wave of patients that we are going to be supporting for end-of-life care. But this meant that our operational imperatives, everything that we did was different. PPE in terms of visiting patients, whether it be in the nursing home or it be in the home care setting. Our office space, this is a snapshot. We predominantly worked in cubicles and open office space, like many industries, many businesses were, and we had to really begin to then move a lot of staff that were able to work from home. manage that kind of anxiety. A lot of our days, my whole day today has been Zoom meetings, as I think with most folks. So a lot of those kind of things were being put into place with it. And the thing that I want to really emphasize, particularly from the home care perspective as well, is that, you know, our nurses and rehab professionals and folks that are going into the homes, they don't have the option to work from home. They are working in people's homes, you know, and so putting together those protocols and testing and those sorts of things to ensure that they would keep safe was one of our highest priorities with it. And then, as Mary Beth had mentioned, the challenges of the nursing homes and assisted living communities. And I know there's my colleagues on the call that we're dealing with this every single day. Of all of these kind of different pictures I put up here is because of the challenges, you know, in terms of having adequate PPE. This was magnified in particularly some of the rural nursing homes that did not have the resources or the ability to tap into infection prevention experts at the medical center and other places. The isolation and loneliness, and that's sort of a whole topic in itself from there. I put the picture, I just found it from the internet, but in a worker in a garbage bag, you know, in a rain poncho to use as PPE. That was real. That was real as people were running out of this kind of protective equipment. And then the disheartening thing, and we've talked about this as well, is the, you know, the media coverage then, and particularly the nursing homes across the pandemic, not just in New York State, but across nationally as well, is, you know, all about this high mortality and the failings of the nursing home. And I can tell you, I mean, there's always bad apples in the bunch from there. But I can tell you is that the workers in the nursing home were on the front line of attempting to do the best they possibly can in extraordinary circumstances with limited resources. You know, these are folks that really care. They would not have a choice to isolate these residents from their families and to put them at risk with it. But a lot of it was a lack of knowledge, a lack of equipment, and a lack of resources and support, as Mary Beth had talked about, was the perfect storm. It was the perfect setup for us having a crisis in many of the long-term care facilities. The loneliness and isolation, I just want to point out as well, the lower right-hand picture of the woman in the window on the phone, that's my grandmother, who's in her late 90s with dementia, and it affected our own family. You know, this isolation, not being able to connect, and finally, it was my aunt who made the decision to take her home and is caring for her at home now, and that is a whole nother set of circumstances and challenges that need to be sort of put in place to accommodate that kind of care. And finally, I just want to leave with these ideas is that as Mary Beth had set up this idea of the palliative end of life care, the particular challenges we had with our hospice team is particularly providing care within facility-based settings. So congregate living settings, assisted living communities, nursing homes. They were frightened. They were starting to close down in terms of visitors and staff, and it was very difficult to even just get our hospice staff, our hospice nurses, our aides. I'm still not able to, for most facilities, to get any chaplain support or clergy support in person into these facilities. Most things have to be by telephone visit or video visit and coordination support of the family in those kind of manners. The families remain disconnected, and there's been some revisions now from the Department of Health about testing and intervals of when no positive cases are detected in a nursing home, which are extremely complex and are still going to be burdensome and challenging for families to navigate that. The workforce shortages, as Mary Beth had alluded to as well, is not only did we think about that we need a trained and competent workforce to be able to handle really this new crisis, but you know, we've had stories of many of the nursing homes that half the staff didn't show up for their shift. You know, they were frightened. They had childcare responsibilities because their kids weren't in school. There was a staffing and continues to be a staffing crisis amongst many facilities of just trying to meet the basic staffing standards and needs. And so what implications does that have? Now, you ring a call bell within a facility to address things like pain and toileting, dignity issues, falls, those sorts of things as well are all going to be impeded by this fact of having reductions in the staffing. It takes more time. If anyone is working in PPE, it takes more time to do just the effort and the task that you normally would be able to kind of whip through in terms of your day and be able to do that as well. And we continue to have these persistent visitation challenges, both in the hospital setting, which still is limiting many visitations, but across all of these long-term care settings as well. And so how do we balance those sorts of risks as well as that kind of protection is still the questions that we're struggling with. I don't want to end on a down note. I think that there's been many challenges and continues to be, but many opportunities as well. It has allowed us to look at a lot of our emergency preparedness ideas, the crisis standards of care, as Mary Beth had talked about. But also I think it has raised really some very serious questions and is going to require a concerted effort to think about what is the viability of long-term care as a system, the supports and resources and services. But also it gave us a tremendous opportunity to have new system-based collaborations, to deploy telehealth technology like we have not before. We were sort of dabbling in, but now we really have brought that to scale. And to really look from a research perspective, I'm a researcher as well. And so through that research lens, how can we do things better for the future? So that kind of just sets the stage then for us to sort of think about what are some of the on the healthcare side, some of the clinical issues that we have been addressing along the way. And I would like to now invite Anne-Marie Cook as our next presenter. Anne-Marie is the president and CEO of Lifespan of Greater Rochester, is one of the major aging service network providers in our area, both in Rochester, but also across the Finger Lakes region, to share a little bit about perspective in terms of the community-based services. So Anne-Marie.
Thank you so much, Tom, and thank you for inviting me. As Tom said, I'm Anne-Marie Cook, president and CEO of Lifespan of Greater Rochester. And for those that may not know, we're a nonprofit aging service provider. We help older adults take on both the challenges and opportunities of longer life. We have 30 different services, everything from a plethora of nursing homes to geriatric care management to elder abuse prevention. And last year we served approximately 43,000 older adults, family caregivers, and people with disabilities. I will focus my remarks really on what happened during COVID in terms of community-based services. And I have this listed as 4 phases, but as you can imagine, it was not linear. First, we had really the lockdown, I will say, phase and what people needed. We also have seen healthcare access challenges and what we've done, the serious issues of isolation, and then I will touch upon how we're trying to prepare and guess what we will need for the winter months when people are back inside. So first, the lockdown, I will just have to say, I will never forget it. On March 13th was a Friday, and we began here to prepare for emergency services. And by Monday, March 16th, our phones were ringing off the hook as older adults, rightfully so, were told to stay home, but they had no food. It was that basic, it was that immediate. And since March 16th to I think these numbers are at the end of July, we delivered over 5,000 boxes of groceries. We're continuing to do that. We've delivered almost 6,000 meals that were already prepared. And I'll never forget one man telling me, I have a sleeve of Ritz crackers left. That's it. And I'll try to make it last whenever you can get me groceries. I think it uncovered for me truly older adult poverty that is so hidden. We also saw that people completely ran out of prescription drugs, necessary drugs like insulin. I had my staff running around getting people's prescription drugs. Since then, we have now provided them mail prescription drugs, but this is what happened immediately with this COVID-19 crisis. I think the other thing we saw was huge healthcare access challenges. Lifespan, as I said, runs 30 different programs. One of them, volunteer transportation to doctor's appointments. We do about 22,000 doctor's appointments a year. We had to shut down our services immediately because our drivers were older themselves. We had no access to physician practices, although most of them closed for a while. Our older adults that we serve have multiple chronic conditions, very vulnerable. And in the beginning, as we all saw, even with Tom's slides, PPE wasn't available, and we weren't even sure what was appropriate to tell older adults to do. I think a key thing we saw was there's a huge digital divide between low-income older adults and other people. And as healthcare opened up through telehealth, older adults just didn't have access. So we purchased 20 Surface Pros so that we could have our staff go to older adults' homes, get the appropriate consents available so we could help facilitate that healthcare access to very vulnerable people who are living in the community. Another very serious issue that continues, and right now I feel like it's very heightened, especially with people in nursing homes, is this feeling of isolation. We have seen the stress, anxiety, but really just feelings of loneliness. This person said to us, everything is doom and gloom and I miss people. I think we can all appreciate that. What we've done at Lifespan is really, first of all, reinstituted an old program we had using the old-fashioned method of the telephone. We used to do daily hellos to people all the time, and that kind of died out. But very quickly, we reinstituted what we call Silver Line New York. We have 360 plus volunteers agree to do this. They've made over almost 5,000 calls, 1,300 hours of just connecting to older adults who live at home. Then the other thing we did was really start outdoor programming. Even in this slide, I'll tell you the other day, this was last week, Monroe County's public health director, Dr. Mendoza, came to speak to one of our group, our senior centers, who have now moved outside in the park. As you can see, they're social distance, they have masks on, but they have been very clear to us, we need to see people. And so we're trying to take advantage of the good weather now and offer chronic disease self-care management classes, educational programs, anything we can do so that people can connect. Another thing we did, thanks to the New York State Office for Aging, was we were able to distribute about 400 robo-pets, both electronic cats and dogs. And you may think, does that make a difference? I'm shocked at the difference it made in people's lives. They really purr or bark, they move, and really just fighting the loneliness, these robo-pets have helped. And one key thing I have to say, I am very concerned about long-term care right now because we have been hearing from caregivers since the beginning, but the anxiety is getting worse right now. It's been months. We're hearing caregivers say, I think my loved one is rapidly deteriorating. And this one call I took personally, this person said to me, today's my mother's 100th birthday. I dropped off a cake at the door, but she couldn't receive it for 3 days. I just don't know about her care, how she's doing. Can you please help me? And I think that's how a lot of caregivers are feeling right now. And we don't even have access right now is the Ombudsman program. We serve as long-term care ombudsman in our region, and we have not had access to long-term care. As Tom said, it's not the workers. They're part of the heroic healthcare team. But as we all know in long-term care, families play a critical role, and it's been a long time for people. I also want to just jump and talk about elder abuse. Lifespan has a long history in providing elder abuse prevention and intervention services. And we operate, among other things, the New York State Elder Abuse Coalition. And you can see listed there a whole lot of things that we're involved in elder abuse. So we handle elder abuse cases that, really all of these definitions except for self-neglect. And we know a few things, critical things about elder abuse. We were involved in a study with Weill Cornell and the New York City Department for the Aging in 2011. And we learned so much, but I want to talk about 3 critical points. We know that 260,000 older adults in New York State will suffer from abuse this year. Most of it we won't know about. Only 1 in 23 cases we'll ever hear about from any formal system. And the most common form of abuse is financial exploitation. So you can imagine my concern, our concern here when initially when COVID hit, almost the cases stopped coming because our referral sources typically isn't the older adult themselves. It's people who see older adults, doctors, bank tellers, other family members. So our cases dropped completely for emergency respite services. And usually this is this service in which I'm running out of money each year. Just to give you some comparison, in April, we saw 25 referrals. We received 25 referrals. In August, we're back up to 90, and we're still not at the numbers that we typically see. We also, scams for us isn't part of our elder abuse team, but it's a different team, but we have seen a huge increase in scams, phony contract tracer scams. We always see Social Security fraud, but stimulus check fraud. You know, you haven't received your check, for $50, I can track it down for you. Fake vaccine scams. So we've seen a plethora of scams pop up as a result of COVID-19. And kind of in conclusion, I just have to say, you know, I think that COVID-19 has sort of highlighted a lot of different things for us. One, that we really need a better systems integration approach, better connections to healthcare, better connections to other nonprofits to help us really support and serve people. I think it shows the necessity of the Aging Service Network, and we need more evidence to prove the work that we're doing, because honestly, some of these older adults would have not received basic needs if agencies like Lifespan didn't exist in the community. We have seen huge workforce shortage concerns. As Tom alluded to, Dr. Caprio alluded to, older adults just aren't going to the hospital, certainly not going to long-term care, but their needs require sort of that kind of home care help and support, and there's huge shortages right now. Elder abuse, I talked about this, it happens in every single community, and we need to protect people from abuse and mistreatment. But first thing we need to do is identify that abuse. I'm very concerned about that. And certainly we need more evidence, need more help from the State Society of Aging to try to figure out what older adults need in the community. In addition to that, of course, trying to serve all these people, and we have funding challenges from the state, the federal government, and local governments. And so I think our advocacy right now in this pandemic is we have to challenge ourselves. Like Mary Beth said earlier, what do we need to do different? We need to reset. We need to pause for a minute to understand what were the successes of how we were able to support older adults in the community, but also what things didn't work, so that we can create a system that works not only for older adults, family caregivers, but for all of us who work in aging. Thank you very much.
Thank you, Anne-Marie. That was a great overview, and I can speak personally about how much Lifespan has helped out a lot of folks in our community right now during this time. I would like to now turn things over to Melissa Lang. Melissa is the president and CEO for the Agency on Aging of South Central Connecticut, and will give us her perspective on the community-based services and how it had impacted the older adults that her agency service.
Great, thank you, Tom. And Laura is going to share my slides for me. So I am the president and CEO of the Agency on Aging in South Central Connecticut, which is the greater New Haven area and up through the Lower Valley. And we provide services and supports for older adults so that they can remain in their home, remain independent, empower them to make choices, and offer opportunities for community and engagement. So starting with sort of just a sense of an area agency on aging. At my agency, we were both an area agency on aging, and then we were also an access agency. And I really want to kind of discuss both of those perspectives and in relation to COVID. Next slide, Laura. So at the area agencies on aging, my agency was started in 1973. There are over 600 agencies across the nation that are referred to as AAAs. And broadly speaking, we do these four categories. We do planning and program development, home and community-based services, information and assistance, and caregiver assistance. And I really want to focus on that on-the-ground organizations. We were really established as agencies back when around Medicare and Medicaid was established, and it was really looked at to be the go-to agency for older adults who wanted to remain in the community. Next slide, Laura. So from the two perspectives of what my agency does, we do the Title III funding for in-home and community-based services. And this is a snapshot of what we do through Title III funding. So we do supportive services, transportation, case management, homemaker chore, legal. We provide support for adult day centers, senior centers. The biggest portion of what we do is nutrition. We do congregate and home delivered meals to roughly 4,000 people. We do a lot of information about chronic disease self-management and offer support to family caregivers. That's a snapshot of what we do on the area agency side. On the other side of what we are an access agency for Medicaid and state-funded programs. So we do the Connecticut Home Care Program for the elderly. We do Money Follows the Person, PCA waiver, and Community First Choice. The home care program, we service roughly about 4,000 individuals in that program. Money Follows the Person is the program that allows people in nursing homes to take that money and rebalance that in the home setting, and we help them make that transition through finding them housing, work with housing coordinators, use their budget to help them with furniture. We do their care management and really coordinate their services over time. PCA waiver and Community First Choice are programs that allow people to remain in their homes and self-direct their care. So on the Medicaid side, we're really working with Department of Social Services in Connecticut, and on the Title III side, we work with the State Union on Aging. Next slide. So first, from the Area Agency on Aging perspective for Title III and what we experienced, in the first phase, it really was all about food. First of all, we had a number of senior centers that closed that served as congregate sites, so we had to take those individuals and give them home delivered meals, as well as individuals that were calling us because they couldn't get out, they didn't have access, they didn't know what to do. So in addition to taking everyone that we traditionally were providing nutrition for, we had a whole host of people that we had to bring onto the program. Online food shopping was very difficult for this population. We were happy to see that SNAP requirements allowed using cards online, so that was really helpful throughout this whole process. But really that initial phase was how to make sure that people got their meals on time. Ongoing throughout COVID was really navigating all of the critical health and social services that people need. The traditional information that they needed about access to their insurance coverage, which was ongoing, their SNAP enrollment, increasing clients, again, from the home delivered meals to all of the newly eligible clients that were coming on board. And we got a lot of calls about technology and scams concern. When the stimulus payment came out, there was a lot of calls that we got around concern about scams, and calls from people who also were currently in nursing homes that wanted to transition back to the community. Chore services requests, people were hearing about sanitizing and they wanted help in their homes. And then ongoing, what we really saw was a decrease in medical transportation. So other than dialysis and chemotherapy, all the other medical transportation really decreased. Referrals to our National Family Caregiver Program that we have, along with our statewide respite program, were decreased because families were home and people were a little concerned about having other people come into the home. So some of the referrals to that decreased over time. Next slide, Laura. So we were on the benefits of getting two additional payment sources during COVID. First was Families First nutrition services, and that was really to give us additional supports and services to be able to accommodate all of the increased needs that we saw with people who needed home delivered meals. So that was really helpful. That came out first, and it came out very early. So we were very lucky to be able to receive that support. We also received CARES funding, these are the traditional supports and services that we offer, our supportive services, nutrition, and our family caregiver, but it allowed us to deepen the support that we were offering. So we were able to develop some quick new programs to fill gaps. We were able to deepen some support. We have a number of agencies that we work with in the the community, and we could give them additional funding as they expanded their programs, and many of them stayed open and really tried to reach more people that needed that support. Next slide. So throughout this, in addition to all of the traditional services that we were offering, there were some gaps that we had to address. The first was people who really couldn't get out, maybe weren't eligible for home delivered meals through our Title III program. So we developed a grocery bag delivery program, like so many did across the country, in really helping older adults by going out, doing shopping for them, and then delivering it to their doorstep on a regular basis. As this program developed, we continued and we developed partnerships with food pantries in the area so that we could provide both shelf-stable meals and then some fresh shopping for all the individuals who were on the program. Isolation and loneliness was a major concern for us. So a lot of what we do on a regular basis, we really want to empower older adults. And here we were in a situation where now we're telling everyone to stay home and we're calling older adults vulnerable. So we wanted to do as much as we could to really reach out. We did a lot of telephone reassurance, just like Anne Marie had mentioned in her community. We were connecting with thousands of older adults by telephone, just seeing how they were, checking on how their needs were changing during the crisis. And they were so grateful for that, saying that our calls were really sometimes the only people that they were talking to. We also made an effort to really continue to try to do what we may traditionally do, which was celebrate older adults. We have an annual art show that is really widely participated across the state, and we decided to make that virtual and work with some senior centers and reaching out to their participants to really continue that process. And we were happy to say that we got several hundred people participating in that art show, and it continued. It went viral in May, and so we were really excited that we were able to continue to do something. Technology was, of course, like others have said, a theme throughout our crisis, and really how do we continue to reach out to our network in the community. There was a lot of concern about people who didn't have access to certain technology. So we've been working with a program to help older adults stay connected by screening them for social isolation and then providing training for them for access to technology. We give them tablets, we do training, and really work with them on that. In addition to that, we're really trying to do as much as we can do to remain all of the things we would have done. We always have an annual conference that is on elder abuse, scams, and fraud, which we get usually about 700 people attend. We're doing that virtually, and we already have 500 people registered, so we're really excited about that. But we really are trying to do everything that the community has expected us to do over time, and how to adjust that. Next slide, Laura. So in addition to the core services that I mentioned through all the Title III funding, we just had a number of calls from people where our staff were really working one-on-one with individuals. And this is just one story that was really representative of the time that we were working individually. Mary, she's 87, she is independent and wants to remain independent, but was very restricted in being able to go to the grocery store. And at the time, the SNAP assistance didn't allow for online shopping. So we have our grocery bag program. We purchased food and delivered the food to her, fresh food and some shelf-stable food, and did that for her over time, giving her several bags through a lot of the state and local partnerships that we have. And when the state began allowing SNAP purchases to be made online, one of our counselors worked with her to develop an Instacart account so that she could continue to shop and remain independent. Next slide, Laura. So very quickly on the Medicaid side of what we're doing as an access agency, initially we was slightly different. Food was not as critical as we were finding on the Title III side with those individuals. But really it was, in the beginning, it was really the technology aspect of clients not able to see their doctors and not having access to technology to be able to do some of the telemedicine. So while everyone continued with their home delivered meals, there were some clients that we really needed to broaden that and provide shelf stable meals. Ongoing, what we've done is we've worked with our state partners, because as of the middle of March, all of the in-person home visits, everything that could be done virtually or by phone was transitioned over to do that. So we started doing all of our assessments by phone and really working back and forth. So we're really trying to figure out, you know, how to do the care management and develop the relationship with the client and do everything that we need to do with our universal assessment to make sure that we're providing the best care. So with that, that was really the initial piece of how to maintain, get up and running, provide that support to clients, the coordination of care that they need, and put those services in place in the home when we're not able to see those clients face to face. For MFP, which is the money follows the person, we had a lot of people that were in transition coming from nursing homes back into the community, and we continued those transitions, and there were some new transitions and people who, because of COVID, really wanted to be in the home. So again, that was very challenging to try to do that when everything was shut down and trying to get housing permits and everything that you need to do when a lot of the agencies were closed. So a lot of creative work done by our staff and our state partners and how to continue those transitions. For PCA and Community First Choice, it was really about getting PPE out to the caregivers in the community to make sure that people felt safe in their home with caregivers coming into the home. So what we're working on now is really looking at the protocols that we put into place for suspending some of these in-person visits. You know, what will we do now? How will this continue? When will we transition back into the home on more of a regular basis? And what have we really learned from this process, and what can be done in these crisis situations? Next slide, Laura. So very briefly, what we've done in sort of our recovery phase is that we've had some recovery committees here in Connecticut really bringing together a variety of sectors, so government, business, and community-based organizations. We've been working on COVID, but we've recently had a lot of storm problems. We had tornadoes here in Connecticut, so having this weekly group, we've really been able to respond and work together. We've modeled best practices in remote work. We've really had to adapt to a lot of the evolving guidance from our federal and state partners, and really working to intervene for people who really had more urgent and complicated needs. And then we're really looking at developing a framework going forward that really encompasses food security, healthcare access, technology, mental and physical well-being, and economic security, all the things that Anne-Marie also touched on in her community. Myself and the other AAAs in the state, there are 5 of us, we're really working together on community conversations. So we're bringing together all different services in our communities and working across sort of our regions to think about how we can share resources. What are our best practices? What did we learn? You know, there's a lot of discussion, and we often hear that our aging services are fragmented or piecemeal. So we have an opportunity here to really think about how can we coordinate our services and what have we done over the last several months that's worked. Next slide, Laura. And then finally, a lot of what I heard from Mary Beth, from Tom, and from Anne-Marie is really about the integration going forward. So we know that older adults need this coordinated support, but what can that look like going forward? We've developed a lot of different services and supports and addressed some gaps along the way with COVID. What can we do to really develop this in a way that looks at it more of a system-based approach, like Tom mentioned? You know, all of the community-based services that we work with here and across the state, everybody provides a critical services. And if we can coordinate those efforts and really integrate both the physical side and all the social service side, that we can really look at a fully integrated service support system. And we see that a lot of the best practices are unfolding, and the agencies are really reaching the most marginalized and underserved areas of our community. So we really provide that platform to be able to learn from COVID, to look and see what we can do to be able to develop what Mary Beth calls palliative environments, so that we can integrate all of the areas that we know palliative care is most successful when those areas are coordinated and when there's communication and new models of care. So what we're really working on here with my other AAA directors is what is that going to look like in the future, and how can we share those resources and then share with the community a new framework for how to reimagine what aging services can look like. And with that, I will pitch it back to Tom.
Thank you so much, Melissa. Your agency's doing incredible work. It really, I'm very impressed every time I hear more about it. We're going to transition here and get an international kind of perspective on things. I'm so pleased to have connected with Katherine Pettus. Katherine is the Advocacy Officer for the International Association for Hospice and Palliative Care. She's going to share some sort of global perspective, the international perspective, and some of the great work that she's been championing. So Katherine, the floor is yours. You'll have to unmute yourself.
Thank you. And what incredibly impressive and humbling work you all are doing. I am going to zoom up to the international level, as Thomas said, and talk about the advocacy that we do in the International Association for Hospice and Palliative Care, which is a global membership organization of palliative care workers. Oops, here we go, down here, right. So one caveat in terms of the older persons movement, because you may or may not be aware there's a global movement for the rights of older persons, for a convention on the rights of older persons. It's being expressed that way now through the United Nations. That sometimes I have a bit of a hard time getting traction for palliative care and long-term care in that movement, because they want to emphasize that older persons, the fight is not just for care, it's for agency, it's for healthy aging and the struggle for recognition of agency and rights. And I would also just throw out the question that are all older persons inherently vulnerable? Because that word has been part of the narrative, especially around COVID, vulnerable older persons. But really, and I saw this word in Melissa's presentation just now, many are simply underserved, and that came out in all your presentations. And when you change the narrative and the framing from vulnerable, which is an attribute of the person or the social group, to underserved, then it becomes a policy issue, and then it becomes something for advocacy. So our main involvement on palliative care for older persons is with the UN Open-Ended Working Group on Aging, which meets once a year and wasn't able to meet this year, unfortunately, because of COVID. And in 2019, there was a whole day of discussion on long-term and palliative care and what the normative elements would be of a right to long-term and palliative care were a convention on the rights of older persons to be approved. But the main thrust of the movement is against ageism and understanding what ageism is, both structural and personal. So the UN is an older person officially. It's the UN's 75th birthday this month, which is very thrilling. And I think we all need to celebrate the UN and multilateralism, because they've done a lot, especially lately in the last maybe 10 years or so, for older persons and for palliative care. It's a fight to get a seat at the table. And we have to struggle with that because civil society, according to UN definitions, is called the third sector, along with business and member states. And sometimes that third sector that we are doesn't always get an equal voice at the table, even though the UN considers civil society as essential partners in the work of the organization. And that's because we deliver services on the ground. And for instance, our members are experts in delivering palliative care, just like the people who spoke before me, all the panelists, are experts in delivering palliative care and social services. So we are considered essential partners, and we need to claim that role through advocacy. As I said, the struggle is to claim a seat at the table at all the UN organizations, especially now with COVID, because one of the things that the evidence is showing is that in many countries, the vast majority of the country's COVID responses, the health sector and the civil society sector have been marginalized from the quote unquote building back better in COVID response. Astonishingly enough, it's mostly security and finance who are in the lead on that. So very briefly, IHPC's global health governance role, because that's how we intervene through advocacy, is through governance. We are what's called a non-governmental organization, as many of you are, in what's called consultative status with the UN Economic and Social Council. And we take a rights-based approach. In terms of the World Health Organization, we're what's called a non-state actor in official relations. And our focal point, because all the non-state actors have to have a focal point within the organization, our focal point is the medicines division. And one of the main areas of work besides older persons that I do is access to controlled medicines, which as essential palliative care medicines, many of which are controlled under the international drug conventions. So there's a whole lot of advocacy to be done at the Commission on Narcotic Drugs in Vienna and with the International Narcotics Control Board, which I'm not going to have time to go into today. So the underlying assumptions of our advocacy are that palliative care and access to palliative and long-term care is a right. It's not a privilege, and it should be provided at the population level. In contrast to, but along with, the services provided by charitable, faith-based, and philanthropic organizations, which can only meet a fraction of population need. And that makes palliative care a privilege for those who are lucky enough to get it if, as they say in the States, if you live in the right zip code. Same in the world. If you live in a country where palliative care is integrated, and there are very, very few of those countries, perhaps 20, 30%, depending on how you calculate that. It's a privilege now to get palliative care. It's not a right of universal access. But government partnerships with palliative care organizations on the ground and civil society organizations such as ours are essential to make that right implemented as per the commitments of member states in the Astana Declaration of 2018, which was the 45th anniversary of the Alma Ata Declaration, which some of us are old enough to remember, on the right to health care, and the Declaration on Universal Health Coverage, which also integrates palliative care as an essential service. So a few of the birthday candles for the UN for older persons and the right to palliative care. I'm just going to give a shout out to some of those. Mary Beth talked about the World Health Assembly resolution that was approved and adopted in May, which provides for palliative care and mentions older persons. But I would say, Mary Beth, that palliative care was not in the original version of that resolution, in what's called the zero draft, which was presented by the European Union. It was conspicuously absent, as it is in many of the UN and WHO reports and drafts. So fortunately, thanks to the advocacy of Bangladesh and Zambia, where we have advocacy focal points who we work with, the mission representatives doing the negotiations for that resolution insisted on the inclusion of palliative care. But that's the way we have to keep struggling for that seat at the table, because otherwise it's left out, it's marginalized, and palliative care is then a privilege and not a right. So there's also the WHO temporary guidance on clinical management of COVID-19, the first version of which came out, I think, in March, and didn't include palliative care for clinical management of COVID-19. So again, we did some advocacy through our role as a non-state actor with the World Health Organization, and ensured that palliative care was included in the updated version, which it is. And there are some excellent sections on older persons, palliative care, and ethics. And Mary Beth mentioned the principle of non-abandonment, which is central, equal moral respect, which we didn't see a lot of in the pandemic, especially in the original responses, and an absolute stipulation that palliative care should be universally available in all the sites where COVID patients were treated. So even basic community level palliative care has to be available in the COVID response. Then just last week, on September 11th, the UN General Assembly approved a resolution on comprehensive and coordinated response to COVID, which calls on member states and other states to address the disproportionate effects of the pandemic on older persons, to promote their dignity, which there you've got palliative care. I don't know why my slides are skipping there. And also the right to the highest attainable standard of physical and mental health. And we've certainly heard in all the presentations today that mental health is being seriously, seriously compromised, both in the older adults and their caregivers, and family members, of course. So all these, even though it doesn't include the words palliative care, this General Assembly resolution can be leveraged for palliative care advocacy and policy development. Regional human rights laws, since we are in the Americas, we are fortunate to live in a region where we have a convention on the rights of older persons, which has a stipulated right to palliative care and pain relief. And then the Organization of American States passed a resolution in May, which talked about prioritizing older persons in programs to respond to the pandemic, and that access to COVID should include testing, timely treatment, access to medication, and appropriate necessary palliative care. So I've included a link to that resolution and just mentioned that the International Association for Hospice and Palliative Care is in official relations both with PAHO, the Pan American Health Organization, which of course the US is a member of, and the Organization of American States, which of course the US is a member of. The ethos of advocacy for older persons' rights to palliative care is an intersectional ethos, and that entails alliances with other human rights-based civil society organizations, such as those that advocate with and for persons with disabilities, refugees and migrants, persons experiencing homelessness, incarcerated persons and their families, which in the US is an immense problem in the prisons, and the LGBTQ community, and of course the faith-based and secular humanist communities. So we try to work with and for all those other communities that need palliative care and embrace older persons. So thank you, and the takeaway I would say is that advocating for older persons' rights strengthens civil society, which is often undermined by governments, and reframes the global health narrative away from reduction of preventable mortality. That's the watchword for global health. The ideology of global health is about reducing preventable mortality. But it's also very necessary, obviously, when mortality is staring us in the face, as it certainly has in the COVID pandemic, to make sure that there's other frames and narratives that we're going to apply to that. And advocacy counter-institutionalizes ageism, the way we do it, and makes older persons more visible to policymakers. So that's one of the things we try to do. The other thing I would say is I spent some of the morning in a webinar with the new Special Rapporteur for Health, and she's from South Africa, and she called for all civil society organizations, so including those such as yourselves, to inform her about what you're doing, and her priority is the most vulnerable, the most marginalized, and putting that at the center of the right to health. So that's all I have for now, and for more information, that's my email. Please join IHPC and subscribe to our newsletter. Every month I write articles on policy and advocacy and the international scene. So thank you.
Thank you so much, Catherine. That's great international sort of framework to give us a better sort of understanding of a lot of the initiatives and a lot of the discussion, and it brings so much to the table with that. And thank you again for your work. I'm going to now kind of bring this to a conclusion by inviting Carla Usher to give us some perspective as well. Carla, I believe you are a law student in Vermont now. Is that correct? With some virtual learning that's occurring as well with it. So thank you so much for being with us this afternoon. The floor is yours.
Thank you so much. I first want to thank Mary Beth and everyone assembled. This is really a really good opportunity for me to speak really from the perspective of what I experienced from the community perspective with regard to my dad, who passed away this past April. He didn't pass away from COVID. So while he didn't pass away from COVID, the entire spectrum of handling or managing my dad's health, you know, during this COVID period, you know, is something that I still, you know, I still am just, at times it's just really daunting because as a lot of the presenters talked about, you know, back in February, January, February, it was a lot of, for us as a family member, we were scared. The first place that you think of taking your loved one when they're in need of help is to the hospital. But the hospitals became pretty much the last place where you would take them for the reasons that have been discussed. I think that when COVID really came into the horizon, you know, I was at law school. We were heading into spring break. And when I heard how COVID affected people with underlying health conditions, immediately my heart sank. For the past 12 years, my father had chronic health problems, among which was he suffered from diabetes, he was diagnosed with congestive heart failure, and he previously suffered a stroke. He was 79 years old, an African-American man. So for that, I just knew that it was gonna be my role as my dad's advocate, which I've been for 10 plus years, without COVID was challenging. Meeting with the doctors, social workers, just being able to just step in as an adult and basically manage my dad's healthcare needs. And now in the COVID world, it just became frightening, to be quite honest. So I come back to New York and my dad's health just started to slowly decline. And that period, you know, first my dad was placed, so I experienced different levels of care in terms of with my dad. There was the acute care hospital where he had been in and out of leading up to the period where COVID really became, you know, was really impacting New York. And then the next stage was that end of life care hospital. You know, where at that stage, my dad had already sat down with me years before we drafted a healthcare proxy. He made his intentions very clear, and his intentions were that he wanted to transition in his home, and his beloved home was Co-op City. He was so proud to tell anyone that he lived there since 1978. So that's a pretty long time. And then finally, the next level was hospice care. So that's something that was really very interesting because now with hospice care, my dad had nurse practitioners that would come in that would basically assist the healthcare aides that I had 24/7 around the clock. one of the healthcare workers who was my dad's main assistant, she actually was in Jamaica. And when COVID, the closures with the airports, she was stuck in Jamaica. So now I became willingly, one of my dad's aides. And I think in that period, it was basically a struggle to keep my dad COVID free. As some of the presenters discussed, you're talking about, people who would go into hospitals, the possibility of being placed on a ventilator, not being able to see your loved ones. That was something that I just could not bear. So I remember as my father's I just had to keep in mind what he wanted. And for me, that meant that I had to create a bubble, a protective bubble. And I would say for the months of February, March, and April 10th is when he passed, there were no more than maybe 4 people, including myself, that came in and out of the home. At one point, I was able to convince the other 2 healthcare workers to, extend some days where instead of going back and forth using mass transit, can you stay on almost like a semi-live-in situation? Prescriptions, groceries, just being very cognizant of the potential for transmission. I will say that the hospice care facility, the nurse practitioners, they did provide us with as much PPE, gloves. We had the mask, and we were just extremely careful because that was something that, again, I just couldn't bear the idea that my father would die in isolation. I think that what I wanted to, when Mary Beth talked about that initial question of what could have been done better during that whole period, I remember saying to someone that I think the thing that gave me a lot of hope was information. And as scary as it was in terms of the numbers of people, you would wake up in the morning, you would put on the press conference with Governor Cuomo, and he would make these announcements of the number of people who passed away in nursing homes, passed away in hospitals. And I think for me, information was my sword. I could, as scary as it was, I needed to understand what was happening around me. And once I was able to get past the fear, I think that was able to kind of help me marshal the strength to keep everyone, family members. My dad was one of 11 kids, many of whom are on the West Coast, so many of whom are nurses. So I would be in constant contact with them in terms of just my dad's progression. I don't know if there's anything much more that I can add, but I do think that, where we are now in the month of September and heading into COVID is still obviously very much in front of us. We're heading into the flu season on larger levels. I think, I have to credit the nurse practitioners, the doctors. I have to credit the people who I was able to lean on. The aides basically came in and just kind of held me together so I could basically hold my dad together, give him the dignity that I think he deserved. And I think as good of an ending as it could have been, that's what I strived for. And I think at this point I'll end here. Thank you.
Thank you so much, Carla. You're speaking from the heart, and I think you really brought this home to have all of us kind of put into context that it's about older adults, it's about family members, it's about all of us as community coming together. And I love the phrase that you use about holding your dad together. I think that's what we've all been trying to do, is kind of hold each other together, right? Try to find the best path forward as we face the challenges that we've already faced, and then certainly have concern for the future. But I think we're in much better perspective, if you will, from what we've gone through at this point in time. So thank you so much. I so appreciate you sharing your story with us. It was very powerful.
And
Mary
if I
Beth, I want
may,
to turn it back to you. Yep.
well, I just would like to thank Carla. Carla, that was just so meaningful, and I know how brave you are sharing that story with us, and thank you. It's a lovely note on which we can close the program. And Tom, I join you in thanking all of our presenters today. I hope we can do more of this. Christian and SSA, thank you for sponsoring the program, Finger Lakes Geriatric Education Center and the Collaborative, and we hope to have more conversations. Thank you, Tom, and thank you, Laura.
Thank you all. Thank you all for
Stay
joining.
well, everyone.
Take care.
Thanks,
Bye-bye.
everyone.
Thank you.
Thank you.